So imagine this. You've just finished your coffee, feeling like the hero of the theater list, and suddenly the ward sister says, "Doctor, that patient says she was awake during the operation." Now your heart performs a spontaneous Valsalva maneuver. First rule, do not panic, at least not visibly. Second rule, believe the patient. If she remembers your playlist during intubation, we have a situation. Awareness under anesthesia is rare, dramatic, and absolutely not a bedtime story. It needs science, empathy, and paperwork. My name is Haitham Mekkawi, and today we will talk about a warn use in operation room. Now, class, awareness is not when the patient says, "Doctor, I dreamt of you dancing in the theater." That's dreaming slightly awkward, but harmless. Awareness is when they can quote your intraoperative jokes word for word. We divide it into explicit recall, conscious memory of events, and implicit memory, the subconscious kind that hides and causes nightmares later. Dreaming is the third category, for which no apologies needed, just good boundaries. Now, awareness is rare, roughly 1 in 19,000 general anesthetics. That's about the same chance as finding a parking space near the theater at 9 a.m., but in obstetrics, cardiac, Oregon trauma cases, the odds rise faster than the patient's blood pressure during laryngoscopy. And for the unlucky few, it can lead to nightmares, flashbacks, or an uncontrollable urge to Google the anesthetist's name. So yes, uncommon but unforgettable. Now we enter the mysterious zone between consciousness and chaos, the human brain under anesthesia. Our agents work by politely convincing the thalamus and cortex to take a nap, but sometimes the message doesn't get delivered. Think of it like sending propofol by WhatsApp. If the Wi-Fi drops, someone might stay awake. Consciousness needs both awareness and memory formation, and both can fail us at inconvenient times. Not every patient is born equal, at least not in terms of awareness risk. The more adrenaline in the theater, the higher the probability someone remembers it. Cardiac, trauma, obstetrics, these are our adrenaline Olympics. Add neuromuscular blockers and low volatile levels, and congratulations, you've created the perfect storm for awareness. So remember, in anesthesia, the risk factors don't just walk in, they roll on trolleys. Not every patient is born equal, at least not in terms of awareness risk. The more adrenaline in the theater, the higher the probability someone remembers it. Cardiac, trauma, obstetrics, these are our adrenaline Olympics. Add neuromuscular blockers and low volatile levels, and congratulations, you've created the perfect storm for awareness. So remember, in anesthesia, the risk factors don't just walk in, they roll on trolleys. Awareness doesn't usually knock politely, it sneaks in through the cracks of induction, maintenance, or emergence. At induction, the volatile isn't up yet, but the laryngoscope already is. During maintenance, your TVA line says, "I'm tissued," but nobody noticed. And at emergence, we turn off the gas too early and call it smooth wake-up. Each phase has its own potential for embarrassment and documentation. Prevention, my friends, is cheaper than litigation. Check your vaporizers, confirm your pumps, and never trust the TVA line that looks too relaxed. Keep your MAC above 0.7. It's not just a number, it's a lifeline. Avoid full paralysis unless absolutely necessary. Patients can't wait for help when they're paralyzed. And if you have BS monitor, use it. It's not there just to impress examiners. When a patient reports awareness, your first reflex might be to panic, suppress it. Instead, channel your inner diplomat. Sit down, listen, and most importantly, believe them. Then call your senior before Twitter finds out. Go step by step, gather facts, review charts, apologize if there's fault, and always offer counseling. And please, document like your career depends on it, because sometimes it does. Every anesthetist has a duty of care to keep the patient asleep, pain-free, and blissfully unaware of your Spotify playlist. But when something goes wrong, lawyers love to ask, was this negligence or just unfortunate physiology? Enter the Bolam Test. If your peers agree your actions were reasonable, you're safe. So, document like your reputation depends on it, because one day it might. When awareness happens, the mind doesn't just wake up, it remembers. Nightmares, insomnia, fear of hospitals. Sometimes the patient knows your theater playlist better than you do. This is where we swap propofol for psychology. A calm explanation, empathy, and counseling can turn a terrifying memory into a story of recovery, hopefully one that doesn't involve your name too often. The British did something brilliant. They audited awareness across the nation. Over 3 million cases, 141 confirmed awareness episodes, and half involved neuromuscular blockers. Translation: movement saves reputations. The key lessons: keep talking, keep monitoring, and don't assume silence means sleep. As NAP5 says, vigilance is free, but negligence is expensive. Every great anesthetic disaster can be plotted on a timeline. Induction: you rush the drugs. Maintenance: the pump naps on the job. Emergence: you celebrate too early. This table sums up how awareness sneaks in and how to block every entry point. Because prevention, dear colleagues, is cheaper than counseling. And that's the end, folks. Remember, awareness is rare, but when it happens, it's unforgettable for everyone. Stay vigilant, keep your MAC above your stress level, and always check your vapor before your vibe. Believe your patient, apologize like a gentleman, and document like your pension depends on it. That's how we keep the science clean and the conscience clear